Now that you have a feel for the history of the diagnostic system and the concepts that are the underpinnings for that diagnostic system, let's shift our attention to the process by which we make diagnoses. As you have already learned, the current diagnostic manual is called the DSM-5, and it contains literally hundreds of diagnoses and the criteria for it. We make diagnoses on the basis of information. Sometimes that information is self-report. We simply interview the person. Sometimes that information is based on things the person does, which we can observe. Occasionally, we will use psychological tests, which are standardized procedures for gathering information about the individual. What is often overlooked is that physical and neurological exams also help in the diagnostic process. These elements help us to rule out things other than psychological disorders. For example, there are conditions that can create psychotic symptoms that are not the result of a disorder such as schizophrenia, but a disorder that's caused by neurological problems. You'll also discover, and we'll talk about this a lot, that research into psychopathology use these physiological measures a lot because they give us a unique insight into what's going on for the individual. By far, the most important instrument in making a diagnosis is the clinical interview. In the clinical interview, you ask questions, and the individual does their best to answer the questions about what they've been experiencing. Now, the interview also includes observation. No good interviewer would miss the way a person is responding. Facial expression, body movements, all of those things are very important. Prior to the introduction of DSM-3, when it became very clear that DSM-2 had serious reliability problems, research was done on structured interviews. Structured interviews use precise questions with precise order and a precise logic to make sure that everything is covered. The idea of a structured interview is it gives every clinician the same information on which to judge the diagnosis. The reliability of diagnosis is based on two things: the quality of the information and its completeness, and the carefulness of the logic in putting together the diagnosis from that information. Structured interviews handle the first part of that. Now, one of the things that you need to be aware of is that with some conditions, the client is pretty good at giving us reliable information about what they're experiencing. For other conditions, the client is terrible at that. So if the client doesn't have much insight into their symptoms, their self-report may not be terribly useful in making the diagnosis. I mentioned that observation is very important. There is an observational instrument called the mental status exam that is used routinely in psychiatry to identify how well a patient is functioning. Now, this isn't by itself designed to be a diagnostic instrument, but rather to give us a fairly standardized score of the level of severity of the symptoms. Much of it is pure observation. What does a person look like? How are they groomed? How are they acting? What are their facial expressions like? Are they aware of what's going on around them and responding appropriately? There are also parts of it where we actually ask them questions, usually fairly simple questions like, what day is it? Where are you? Who's the President of the United States? How much is 3 times 17? Those questions get a pretty good idea of how well the brain is functioning, because those are questions most people are normally able to answer. In observation in general, we don't just look at the behavior. We look at what are called the ABCs of behavior. Antecedents, the A's, are the things going on before the behavior. It's entirely possible that they are triggering the behavior. The behavior, of course, is the B, and C is the consequence. What happens after the behavior? We know from operant conditioning that what happens from after a behavior will determine the probability of that behavior in the future. Sometimes in diagnosis, we will use psychological tests. And in fact, psychology at one time, that was their primary role, is to do the testing for psychiatrists. What kind of tests can we use? Well, we can look at intellectual functioning, and we have some very good IQ tests for that purpose. But we can also look at various personality traits, and we can look at general personality functioning in what's called personality inventories. Let's talk a bit about intelligence testing. Intelligence tests were first developed by Binet in France, and they had the purpose of identifying who could benefit from education and do it in an objective way. Prior to that, the only way we could make that decision was based on the subjective impressions of teachers. And unfortunately, those impressions can be influenced by other variables. For example, a quiet student might be thought of as low intellectual ability because they're not showing any of their intellectual ability. So by having a specialized test, we could do this in a more objective way. We use a score called IQ, which is defined as the mental age divided by the chronological age multiplied by 100. Okay, so the chronological age is simply the age of the child. If the age of the child is 10, that would be the denominator. The numerator is the mental age. If that child is performing at the level that an average 10-year-old is, that would be their mental age. And so their IQ would be 10 divided by 10 times 100, or 100. But if that child is performing at an age, an average performance of someone who's 12 years old, their mental age is 12. But they're 10. That's their chronological age. So 12 divided by 10 is 1.2 times 100 is 120. And that would be their IQ. So any IQ scores above 100 are above average. And any below 100 are below average. And how far you are from 100 determines how intelligent or not you are. Now, the IQ tests initially measured just the skills associated with classroom performance, which we call verbal. Now, they also included math and some things like that, but it was mostly classroom-like tasks. There's another type of performance measures which have little to do with what you do in a classroom. What's interesting, though, is that verbal and performance measures tend to be highly correlated with one another, which is one reason why we believe that, and at least some people believe, that intelligence tends to be this generic concept that affects all kinds of things. Now, let me just say that's an oversimplification, and we have better models now. What's important is that the IQ test is a score that approximates a measure of something we can't see. That's intelligence. They are not the same thing. An IQ test is affected not only by your intelligence, but how motivated you are when you take the test. The optimal conditions of taking the test and other variables as well. Perhaps the best known tests, and the ones associated with psychologists the most, are what we call projective tests. I'll show you examples of them in just a minute. The idea of a projective test comes from Freudian theory. Remember, in Freudian theory, we're interested in what's going on in the unconscious, which means the person's not aware of it, and therefore the person can't tell us about it. So how do we get at the unconscious? Well, we present stimuli that are ambiguous, and we ask the people to respond to them. And in responding, they have to project, that's why they're called projective tests, part of themselves, including their unconscious, onto those stimuli. And that gives us an idea of what's going on inside the individual, even outside of their awareness. These are examples of the two most widely used projective tests. On the left is one of the cards from the Thematic Apperception Test, or TAT. In this case, the task is for the individual to tell a story, and the story has to have 4 elements. What's going on? What is the person thinking? What led up to it? And how will it turn out? The idea is that no one story means very much, but if consistent themes, remember it's the thematic apperception test, if consistent themes show up, they likely represent something that's going on for that individual. So looking at that particular card right now, if the story they tell is that this young boy needs to practice the violin, but he doesn't really like playing the violin. He would like playing the violin if he could just do it, but he's feeling enormous pressure from his parents to not just play, but to play outstanding violin. And it's been like that for all of his life. And he's becoming aware that that will never stop. Maybe a story like that indicates something about what's going on for this particular individual, or has gone on in the past. On your right is one of the 10 cards from the Rorschach inkblot test. Now you make a ink blot by dropping ink on absorbent paper, folding it over, and then unfolding it. So the ink blots are always bilaterally symmetric. You can use different colored ink, as is the case in this situation. The task is to look at those ink blots and tell people what they look like. Now, to give you an example, typical response is that you have 2 people with red masks on who are playing patty cake, or 2 animals playing patty cake, or looking at the white space in the middle, you have a rocket ship that is going through a series of clouds. The nature of what you see indicates something about your processing. The reliability and validity of projective techniques, even though they're widely associated with psychologists, is fairly low, and as a consequence, these techniques are not used very often anymore. What is used are personality measures, and we have literally hundreds of them. Some are very simple and they'll measure a single trait. Some of them are very complex. Those are called personality inventories. I want to introduce some concepts here before we go into personality inventories in more detail. We make the distinction between face validity and content validity. Face validity is, does the measure what it looks like it's measuring? Content validity is, does the measure what it is supposed to measure? Now, we've talked a bit about this before, but we didn't use these terms, so let me remind you of an example. On the MMPI, which we'll talk about shortly, there's an item. It's true, false. I believe I'm being persecuted against. If you say true, that tends to suggest that you might be paranoid. Now, no one item would be used because there's lots of reasons you could respond to any given item. But it tends to move you in that direction. That's a face valid item because it measures what it looks like it's measuring. Here's another item from the MMPI. Most people will use unfair means to gain profit or an advantage rather than to lose it. Now, it may surprise you to find that that measures paranoia. In fact, it measures it about as well as the other, but it is not face valid. The first one, face valid, we would call an obvious item. The second one, which is not face valid, is a subtle item. But they both have content validity because they both measure what they intend to measure, which is paranoia. Now, all of the personality measures that we're going to talk about are heavily validated, and many of them were based during their creation on empirical data. There's no ambiguity in the scoring. If you say true, you add points to a particular scale. If you say false, you add points. If it's a Likert scale from 0 to 5, for example, the number of points is clearly determined, which means the test can be given and scored by a computer. It doesn't require the complicated decisions in projective tests, for example. The MMPI is by far the most widely used personality measure in psychology. It's short for Minnesota Multiphasic Personality Inventory, and this is the second edition of it. It's been around for well over 70 years. Currently has 566 true-false items, and the people taking the exam are asked to answer either true or false, depending upon whether the statement is mostly true for them or mostly false for them. It has well over 35,000 published papers, so we know an awful lot about the test and the various scales that can be created from those 567 items. It has excellent reliability and validity, and we know enough about how it works that we can do a great job of interpreting the patterns of scores for individuals. Finally, sometimes we need to know something about the functioning of the brain. There are a variety of ways that we can do that. One is called neuropsychological testing. Those are tests of specific behaviors that we know are related to the functioning of specific parts of the brain. We can also do brain imaging, and we actually have two strategies for that. One is called the CAT scan, or CT scan. It's short for computerized axial tomography. The CAT scan uses X-rays to take pictures from many different angles and sophisticated mathematics to create a 3D image that we can view from many different perspectives. By the way, the sophistication of the math and the importance of it led the developers of that mathematics to win the Nobel Prize in Medicine, and it's been used in a variety of other fields as well. An alternative is called magnetic resonance imaging, or MRI. The CAT scan uses pictures created by X-rays, but X-rays are not great things for the body, and that's a lot of X-rays that would be taken. So in MRIs, what they do instead is they create a powerful magnetic field which orients the molecules within the cells in such a way that you can get a very good picture of the brain. Now, brain imaging is helpful if there is clearly a physical problem with the brain. But often the brain looks fine. Everything is where it's supposed to. There are no tumors or strokes that are apparent, but a part of the brain may not be functioning. And so there, we don't want to look at the structure of the brain. We want to look at the functioning of the brain, and we do that with functional brain imaging. There's a functional version of the MRI called fMRI. Again, that uses the magnetic field to be able to get a picture of how active the brain is. And an older technology called PET scan, short for positron emission tomography. In the PET scan, what we do is we use very short-lived radioactive isotopes that will bind to the sugars that provide the energy to cells. The more active the cell, the more energy is absorbed and used, and therefore the brighter the signal. Let me say a little bit more about neuropsychological testing. It's been around a very long time, more than 8 decades, and it has gotten increasingly more sophisticated. At one time, it was the primary way that we diagnosed problems with the brain because we had no imaging technology. So the only other way of finding out if there was a problem with the brain involved cutting away the skull and going in with a scalpel to take a look. That, of course, is pretty dangerous. Neuropsychological testing involves measuring very specific skills, such as how fast you can tap with your finger, or how well you can identify symbols, and tons of research that shows that the parts of the brain that are necessary for each of these tasks are this and this and this. So when we see a pattern of deficits, we can do a reasonable job of inferring what parts of the brain are not functioning. Now again, at one point we used it for diagnosis. We don't use it for that purpose because the scanning technology is very good and rather inexpensive, frankly, compared to neuropsychological testing, which often can take days just to do the testing and much longer to interpret the results. But we often use neuropsychological testing now because by identifying the things that one can do, we're often in a position of being able to help the rehabilitation specialists to focus on those things that the individual can do instead of the way they used to solve problems. Again, our brain is capable of doing things many different ways, and if a part of the brain is damaged, and therefore a pathway for doing a task is lost, we find another pathway. Now, a lot of neuropsychological testing is what we call screening. These are short tests. They really require much less training than neuropsychological testing, and they can be used by psychologists and other professionals to identify whether more sophisticated testing is warranted. These screenings typically, like all tests, will have false positives and false negatives. A false positive is a result that says it looks like there's some sort of brain damage, but as it turns out, that's wrong. A false negative is it looks like the brain's functioning fine, but that decision is wrong. Screening tests in neuropsychology are designed to have much higher false positive rates than false negative rates. We do not want to give a clean bill of health to someone who may have a tumor growing in their brain. So we're willing to tolerate some false positives, which we will, with later testing, be able to rule out, than a false negative that will lead us to not follow up at all. This is a typical neuroimaging machine. Again, this is a non-invasive procedure in the sense that you don't have to cut into the head, or for that matter, any part of the body, to be able to create a very good image of the body. And the machine looks pretty much the same whether we're measuring the structure or the functioning of the brain. These are typical brain scans from a CAT scan, MRI, or a functional MRI. These are what we call slices. The mathematics that underlie brain scanning technology creates a 3D image. But we look at that image by doing the equivalent of slices. Now, this is based on a very old technology. When we would do autopsies of brains, what we would do is slice the brain at a particular point. We might do a slice like this, and we would see some organs very clearly, or we might do a slice like that. And those were literal slices. We basically used a device that allowed us to cut through, and then we could see at that particular level exactly what was going on. With a 3D image, we can create these slices without, of course, damaging the brain, because all we did was take a picture of the brain. And we can view and identify each of the organs. So, for example, if we were to take a series of slices like this, we're going down into the brain, and as we go further down, we're going to see different parts of the brain, and if there's a tumor or something present, we will be able to detect exactly where it is. So this chapter covered a lot of ground. Our diagnostic manual is called the DSM, short for Diagnostic and Statistical Manual. The current edition is DSM-5, although there were 6 previous manuals, because the 3rd and the 4th edition both had revisions. The DSM primarily follows the medical model, but psychology and some of the information that we've learned in psychology is having more and more impact on it with each edition. When we talk about diagnosis or assessment of any sort, we're talking about 2 concepts. Reliability is the consistency of our interpretation, and validity is the accuracy of our interpretation. So we have inter-rater reliability if 2 well-trained people can interview the same client and come to the same conclusion about what the diagnosis should be. Whether that diagnosis has some reality, a common underlying cause for anyone who qualifies for the diagnosis, is a matter of validity, and that is something we're going to spend most of the rest of this course talking about. We also talked about a variety of assessment techniques, from clinical interviews and observation to psychological tests and even physical tests such as brain scans.